the opportunity to share, and we're excited to hear from some fantastic experts who are doing some really remarkable work in this area. Unfortunately, Jenna was not able to join us, and her absence will be felt, but we're happy to share some additional work going on. So perhaps if some of the panelists would be willing to introduce themselves.
Good morning, I'm Joelle Ruthig. I am the chair of the psychology department here at UND. I'm excited for this opportunity to be a part of such an important mental health summit today, so thank you.
Hello, my name's Irene Miller, and I am School of Aviation with Southern Illinois University, Carbondale, and excited to be here. And I was just fortunate to be able to bring one of my students with me. He's through a grant through the Naval Air Warfare Center through the research we're doing. So I'm here as well as my undergraduate research assistant, Tanner Way.
Thank you. And my name is Billy Hoffman. I'm a physician in the Air Force and in neurology, and I get the privilege to work with UND on some pilot health-related research. So how this panel is set up is we're going to spend some time talking about our respective projects, and then we'll have some time in the end to have questions. There's a lot of really amazing work going on in this area, this is just a very small sample of many of the work that the others are doing. And we're excited to share that with you today. I want to share some data with you today that tells a really fascinating story about a problem that is staring us square in the face. And if valid, has the potential to have implications across aviation and potentially even around the world. But through remarkable conferences like the one today and through the work of everyone in this room, to include others, we might have the opportunity to shape the arc of that narrative as we think about what might an aeromedical screening system of the future look like that balances pilot healthcare access and aviation safety. But don't take my word for it. Take it from the word of one of your own. In the spring of 2022, Chris Daniel thought he had it all. A wife, 2 beautiful children, and newly achieving his lifelong dream of becoming a captain at a major U.S. air carrier. But despite outward appearances, Chris knew something wasn't right. Shadows from his past were reemerging, made worse by post-COVID travel demand and long weeks on the road with stress brought home. Years earlier, his primary care physician had suggested he might have symptoms of mild depression, but like many pilots, Chris had balked. If he sought treatment, he assumed he would never fly again. Well, Chris hoped things would get better, but unfortunately, they didn't. In fact, they got a lot worse. And this summer, things came to a T, and feeling that he had no other options, Chris unfortunately died of suicide for an untreated mental health condition. So, what happened here? The views expressed in this presentation are mine alone and do not reflect that of the U.S. government, and I have no relevant conflicts of interest. So, let's take a step back. Chris is among the 630,000 pilots in the United States that functions in one of the most complicated systems that humans have created, and of course, that's the aerospace system, that allows for the safe transport of literally millions of people around the globe every day. And the way that this is able to be achieved so safely is in part related to medical standards that pilots are required to meet in order to maintain their flying status. But of course, here's the kicker. If a pilot develops a new symptom or condition and seeks treatment for it, they're required to disclose it during aeromedical screening, which has the risk of potentially resulting in temporary or permanent loss of their flying certificate. And for this reason, it has been proposed to result in negative occupational, financial, and social repercussions. And in theory, this system should work. If a pilot is healthy, they fly, and if they don't fly, they pull themselves from duty. But it may not be so simple. And going back to our patient, as a clinician who takes care of patients, it's hard not to ask the obvious question. major depressive disorder is a treatable condition with interventions that can get people feeling better. Tessa, his wife, wanted me to mention too, it wasn't just about mental health. There were other physical things that he was very worried about seeking health care over the years too. Why did this pilot die so young of a treatable medical condition? Now, I suspect a whole proportion of folks in this room have a reflexive answer to this question, and that is that some pilots have a worry about seeking medical care because of what a change in health status might mean to their ability to fly. And while that's often common knowledge to pilots and many of the physicians that help take care of them, up until a couple of years ago, this phenomenon had not been very well characterized in the medical literature. And so our group set out to try to answer some of these questions. Does healthcare seeking anxiety and healthcare avoidance exist in the population? And as we began to kind of poke at this story, we've been able to pull at a really fascinating narrative about a big problem that is staring us square in the face. And I want to share some of those data with you today. There's a whole bunch of numbers I want to share, but really these are the two I hope you'll walk away with, and we'll talk about each in turn. So in our first study published in 2019 with about 850 folks enrolled, we asked pilots really the obvious question. Have you ever felt worried about seeking medical care because of your career or hobby? And in that sample, we found that just about 80% of pilots answered yes. Now, of course, these type of data always have limitations, but up until that point, to our knowledge, this was one of the first numbers trying to quantify the prevalence of such a behavior in the population. Well, if pilots have healthcare seeking anxiety, we then went on to ask, have you ever not sought or delayed medical care because of fear of air medical certificate loss? And we found that just about 60% of pilots answered yes. In looking at this number, it's hard not to ask, could there be up to 50% of pilots flying with with medical symptoms or a condition that have not been fully evaluated? In the publication of that first paper, we had so many more questions. If pilots have healthcare seeking anxiety and avoid healthcare, what does that mean for occupational behavior day to day? And that led to our second paper that just published in the spring of this year. That was a tremendous effort with the help of many, many people, to include many people in this room actually, who we are really grateful to your help. And for that reason, we were able to enroll over 4,000 pilots across the United States. To our knowledge, the largest study trying to measure pilot healthcare avoidance in the population. And here's what we found. We asked pilots if they've ever participated in healthcare avoidance behavior. And here's how we defined it. We asked them if they've participated in any one of the 4 following behaviors, specifically because of their fear of losing their certificate. Have they ever sought informal medical care outside of the traditional medical system? Have they ever maybe not told the whole truth on the 8500 or during air medical screening? Have they ever flown despite a symptom, physical or psychological, that they felt needed evaluation before flying but flew anyway? And last, have they ever used a prescription medicine that they didn't disclose? So here's what we found. In our study, to our knowledge, one of the largest on healthcare avoidance, what percentage of pilots freely disclosed a history of healthcare avoidance due to fear for air medical certificate loss? An important point, these are only the pilots who answered yes. All the pilots that didn't answer the question or said prefer not to answer were categorized as no. So we intentionally tried to be conservative, and we'll leave a prefer not to answer or a no answer interpretation up to the audience. Now, there's a ton of data I would love to share with you. Of course, we're limited on time, so one I do want to share with you is this question. Have you ever misrepresented or withheld information on air medical screening? Well, this is an important question because really one of the primary tools that we have to screen pilots for air medically significant diseases by asking them, has this happened to you, yes or no? If the answer is no, oftentimes at that point screening will often stop. Well, what percentage of folks in our sample reported misrepresenting or withholding information? Just about a quarter. Well, what does this mean? It tells us about the big opportunity we have in as we think about a quality improvement framework, how might we be thinking about this in a different way to optimize such a number? If pilot healthcare avoidance exists in the general population, we then asked, does this exist in the military cohort? Interestingly, the structure of the two systems are very different. Of course, in the military, having an assigned embedded flight surgeon either within the unit or within proximity to the unit through flying operations, with the intention being trying to address some of the things in this study. So we set out to try to answer this question, and we just published this in Military Medicine about a month ago. We asked, does healthcare avoidance exist in the population of U.S. military pilots? And it may not only exist, but it may actually be at higher prevalence than in the general population of pilots. And interestingly, we talk about the different cultures that exist in different pilot populations. For example, fighter pilot versus a bomber pilot. Would this influence healthcare seeking behavior? Interestingly, we really didn't find that big of a difference. In fact, we found that the rate of admitting to healthcare avoidance was almost the same in all these different subgroups, suggesting that this behavior might be ubiquitous in the population. Well, we asked questions about healthcare avoidance in the U.S. population. We then became interested if we could try to reproduce these same findings in another population. And we were very fortunate to collaborate with Parth Patel, who's a really motivated graduate student at the University of Alberta, and Dr. Acker, who's a researcher there. And with his assistance, we were able to recruit over 5,000 pilots to do a multinational North American comparative analysis of pilot healthcare seeking behavior and avoidance in U.S. and Canadian pilots. Of course, in the U.S. population, we found that just about 56% of pilots reported healthcare avoidance behavior. But what about in the Canadian population? Does healthcare avoidance exist in Canada? Interestingly, many of these metrics are not the same between the two aeromedical jurisdictions. And for example, as it relates to withholding information on aeromedical screening, if you recall that we had just about 26% of pilots saying that they've withheld information on aeromedical screening. Interestingly, in the Canadian cohort, this behavior was higher. Why might this be helpful? By researching healthcare behavior in different jurisdictions, we may have the opportunity for knowledge sharing and best practices as we think about trying to tackle some of these challenging questions. Now, healthcare avoidance may not only have implications for screening. Most of my time as I see patients, and this is the slide I show all my colleagues at work, that this might result in healthcare behavior that becomes clinically significant in the hospital or in other healthcare settings. So in the study, we asked pilots how likely they would be to seek medical care during experiencing various durations of stable angina. So that's chest pain that occurs from the heart. And the y-axis is likelihood, where the top is very high and the bottom is very low. And of course, the x-axis are various durations of that symptom. In the non-pilot population, we found the expected arc that as these symptoms occur for over longer, these non-pilots are more likely to seek medical care. Well, what about in the pilot population? Interestingly, they not only had lower probability over the various durations of experiencing this symptom, but nearly every single one of them was statistically significant. So what does this mean clinically? When a pilot presents to our clinic or in the emergency setting, we might need to think about diagnostic evaluation and treatment in a more urgent or expedited fashion compared to a non-pilot patient. Now, of all the data I just shared with you, these are the data that I'm the most excited about. There's a lot to this slide, but I think it's really important. We'll talk about each in turn. We asked pilots how likely they would be to use a theoretical intervention to address the barriers they face or the perceived barriers they face in seeking medical care. In the study, we proposed one. It has many limitations, and we could talk about those, but more broadly, we felt that it serves as a marker for interest in such an effort in general. And we broke it down by whether or not a pilot reported a history of healthcare avoidance, yes, no. So, in the left column, what percentage of pilots who had reported a history of healthcare avoidance said that they would be somewhat likely or very likely to use a theoretical sanctioned intervention to address the barriers they face in seeking medical care? 75%. But while this number is very interesting, I think the next one is the one that is particularly exciting. What about the pilots that this issue has not come up yet for them yet? Maybe they're young and they've been otherwise healthy. Maybe they're just lucky and they've been healthy and they haven't had to engage in the aeromedical system. Or maybe they didn't tell us everything in the study. What percentage of those pilots said that they would be somewhat likely or very likely to use a theoretical intervention to address the barriers they face in seeking medical care? 60%. So, what do these data tell us? Pilots may have healthcare seeking anxiety and participate in healthcare avoidance behavior, but importantly, pilots want something. Pilots want something to address this barrier, and in thinking about this problem in creative ways, we have an opportunity to partner with pilots as we think about building an optimized aeromedical screening system of the future. So, in summary, we found that just about 56% of pilots reported history of healthcare avoidance, but importantly, nearly 75% said that they would be somewhat likely or very likely to use a theoretical intervention. Of course, when you're doing research and you have numbers that are like this, it can be easy to think about it at the pilot level or the patient level, but our argument is that we should be thinking about this at a systems level. What are factors in the system that are influencing healthcare disclosure and utilization in the system? And we can be using that as a branch point for further research. Absolutely, there is limitations in these data, and any conclusion should be drawn within that context, but we feel support the hypothesis that these behaviors exist in the population. So what are factors that influence healthcare utilization? What are factors that are particularly supportive in utilization and disclosure? What are factors that are particularly discouraging? These are the type of questions that we're going off in our subsequent study that just launched, thanks to a $750,000 grant from the U.S. Air Force, studying qualitative factors that influence pilot healthcare utilization. We hope that this grant, this investment by the Air Force, serves as a marker to industry that healthcare avoidance is probably not going to go away. In fact, it's probably only going to become more complicated, and we need to be thinking about it in creative ways. And most importantly, we have an opportunity to think about this in a new way. Everyone stands to gain by continuing research in this. For pilots, of course, this is a pilot health issue. In the military, this is a mission readiness issue. How do we maintain our force such that we can maintain the mission with the resources that are available? In industry, this is a cost-saving measure. How do we maintain a fleet of pilots that are healthy to perform the duties? And of course, from safety, how do we optimize safety in the system? So all stand to gain by research in this. In this study, this is going to be a large project actually occurring at 2 different places. UND, we're super excited, is going to be conducting, and of course, Dr. Ruthig is going to talk about that briefly too. But in general, there's 4 populations of pilots, U.S. Air Force active duty pilots, U.S. airline pilots, and then trainee pilots in both of those populations. The importance of the trainee part is critical. The hypothesis is that Gen Z pilots and this population of pilots that is among the most diverse in aviation's history have healthcare preferences and behavior different from their predecessors, and we are very hopeful to try to capture that data in this qualitative study. These are going to be anonymous interviews. In this grant permitted us to hire a team of experts to try to gather that data in a systematic way. The concept of the study is pretty simple. Pilots have opinions, and we just want to collect those in a systematic way. But importantly, to our knowledge, this hasn't been done yet and has the potential to inform research and hopefully policy discussions. The data will center on factors that support healthcare seeking, what are things that are particularly discouraging, but what are programs that already exist that are being used to address this barrier? Things like peer support in the airlines and here at UND, of course, and things like craft programs in the United States Air Force. And lastly, from a pilot's perspective, how do we address healthcare avoidance? Hoping that we can find some, perhaps some obvious things that are hiding in plain sight to optimize the system as it currently exists. In the end, we're hopeful to make this data set available to aviation leaders, such that aviation leaders can mine this data for things that are relevant to their organizations and their teams. For example, you can, based on demographic factors and other qualitative factors, for example, like in peer support, what are things that are particularly supportive or for the questions of interests? I want to leave you with one last thing, and that is, of course, what brings us together is mental health in aviation and how aviation leaders might engage with this topic in the years to come. It's no mystery that certain stakeholders are calling for alternative ways to engage with mental health in aviation, but the big elephant in the room is the lack of data to guide such considerations and potential efforts. And so the primary question is, from a policy perspective, what are the data that are needed to consider how mental health might be engaged with in the future? Recognizing we are just science people, we're not policy people, but how do we get the data available to inform these conversations? Mental health in aviation is a very complicated safety, regulatory, and clinical problem. And how do you design a research study to try to cleanly, study the things that you're looking for? And for that reason, it became clear that a model is needed to frame research questions. And I wanted to briefly share that with you today, recognizing that this is a theoretical model and it's meant for research, not necessarily operational. So this is a research model to frame research questions. That said, we've actually had quite a bit of success in using this, particularly in informing funders of research. What are our objectives? In collaborating with other institutions, what are the open research questions that we need to go after? And lastly, focusing on shared use of terms so we can pool all of our efforts in moving in the same direction. This model is complementary to existing frameworks, whereas SRM and other frameworks have a mishap or a near miss as the center point. This instead has the pilot patient at the center point using principles of population health. In the y-axis are the number of pilots, where the top is many and the bottom is few. And in the x-axis is the continuum of mental health symptoms. And I think Dr. Snyder will talk about the different zones of mental health symptoms, such that on the very left half of the model would be very mild symptoms. Perhaps these are the symptoms that occur in everyday life that would be considered as normal. On the very right half of the screen would be considered very severe mental health symptoms. Now, the population of pilots in the United States falls somewhere on this spectrum. What is the spectrum exactly? Open research question. For the purposes of our conversation, we're going to put it like this. We hypothesize that there's probably a left skew, with many pilots having mild symptoms and far fewer having severe symptoms. Now, as you go from left to right, somewhere along this continuum, the symptoms at some point become aeromedically significant, such that the pilot can no longer perform their routine duties and their duties in extenuating circumstances because of the symptoms. Where does this line fall on the spectrum? Open research question. For the purposes of our conversation, we're going to put the line right there, such that pilots beyond that line have symptoms that are so significant that they can't perform their flying duties, but pilots on the left half of that screen are having symptoms, but they're still able to perform their duties. In current aeromedical screening, through the AME system, we are capturing some percentage of these pilots in screening, meaning that they're coming to their AME, they're identifying as having symptoms, and they're being pulled from duty, or they're getting some kind of SI or other process to continue flying. What percentage of these pilots are being captured or identified in aeromedical screening? Open research question. We would hypothesize that our data suggests that a proportion are not being captured. For the purposes of our discussion, we're going to put the line right there, such that folks below this line are being identified in aeromedical screening, but the folks above it are experiencing symptoms, but they're not being identified in aeromedical screening as it currently exists. The last line I want to put on this graph would be if we had a magical wand and we could capture only the population of interest. Who are the people that were really interesting in capturing during aeromedical screening? Well, certainly it would be folks beyond the right side of the line, but we would, this is an open research question, but we would argue that it would be somewhere right here, approximately, such that there would be a safety margin between aeromedically significant disease and the capture. So in the system, everybody beyond that green line would be flagged as having a positive symptom, aeromedically significant, but most importantly, folks on the other side of that line could be identifying as having mental health symptoms, as needing help, but they're not at risk of losing their aeromedical certificate, and they can continue to perform their duties under appropriate evaluation. Perhaps we all have experiences in pilots in different buckets. For example, the pilots in bucket A are the pilots that we're trying to capture in our data. These are folks that are having symptoms that are participating in healthcare avoidance. Perhaps the pilots in B are the pilots who are following the rules They're not flying, but maybe they could be flying because maybe their symptoms are mild enough to be flying. And then, of course, population E are the folks that are not being captured, but they should not be flying. An example of this would be the tragic pilot of the murder-suicide in Germanwings would be a pilot that falls in bucket E. Like I said, everyone stands to gain by researching a way to go from purple to green. Pilots stand to win in Group A. Industry stands to gain by Group B by increasing the pilots in the pool. And then, of course, we all stand to win by better capturing the folks in E. Our group is going after that red line, and that's what we're hoping to go through next with simulator studies. We have many people to thank, and to include UND, and we'll pause there. Thank you so much.
All right, well, thank you. I am going to talk to you a little bit today. First of all, let me back up. My background is not in aviation, nor am I a clinician, but my background is in health psychology and social psychology. So I'm going to give you a little bit of background on behavioral health models, individuals' perceptions of their health beliefs, the symptoms that they experience, and so on, and talk a little bit more about the study, the qualitative study on pilots' help-seeking behavior that Dr. Hoffman had mentioned earlier. So the big questions we're interested in is what determines whether pilots seek help when they're experiencing a new mental health symptom or a new physical health symptom. Are they even aware of those symptoms, or is their attention elsewhere? If they are aware of those symptoms, maybe they're feeling a bit of depression, maybe they're experiencing some tightness in their chest, or having some sleeping issues, are they just disregarding that and brushing it off as, you know, I've had a tough week and I'm really stressed and I'll just sleep it off? If they get to the point of determining that they do need to seek help from a professional for those symptoms that they're experiencing, how quickly does that happen? When and how does that happen? Now, I've got a timer thing happening here. When we are looking at the sort of initial symptoms that individuals experience, there's all kinds of delays that occurs, and we're not just talking about pilots, right? All individuals, we first of all have to acknowledge those symptoms we're experiencing, and there can be cultural differences in terms of how we experience and interpret new symptoms we're having. So do we determine that those symptoms indicate something out of the ordinary, that we are actually sick? Do we then decide, okay, does this illness or this new symptom warrant medical attention? Even if we get to that point that, yes, you know, this chest pain I'm experiencing, or this lack of sleep I'm having, or these depressive symptoms, you know, I should really see somebody about this. There's additional delay between coming to that conclusion and actually seeking physicians' assistance and receiving the medical attention and treatment and so on. And that's non-pilots even that we're talking about here. So when we layer that on top of that, these different delays, the hesitancy associated with concerns about how seeking help might impact flight status, we have additional delays and concerns there as well. Fortunately, there are a lot of behavioral health models that are available to help us start to examine and identify these different factors that go into explaining the delay in help seeking. There are environmental factors, population factors, and health behavior factors. This model is one such model, C. Anderson Behavioral Health Model of Health Service Use. It's been around since about the mid-1960s. It's been widely established, tested, and revised over time, and looks similar to what we have here today. We are particularly interested in using this model to determine in our research what makes it more likely that pilots will seek help for symptoms that they're experiencing for either mental or physical health needs, and what barriers stand in their way. Sorry about that. In particular, we're going to focus today a bit more on these population characteristics. So what pre-existing characteristics of the pilots themselves, their health beliefs, their health attitudes, their perceptions of health and help seeking, enabling resources, and their perceived need predict their health practices, so their exercise or eating, their sleep hygiene, for example, and their use of professional health services. So just to dig into those factors a little bit more before I get into our qualitative study. The predisposing issues can be things, like I said, health beliefs. What are the perceived barriers that pilots and pilot trainees have to seeking care and reporting the symptoms that they're experiencing? Mental health stigma was one that was mentioned earlier, and that's a big one, right? What is their knowledge about their medical insurance, the benefits that are available to them? How familiar are they with making appointments that they might have, that they might need, particularly to see someone about mental health issues that they're experiencing? Do they know what they need to do to make that happen? What are their thoughts and perceptions about seeking care as a pilot? Are they comfortable with sharing the symptoms that they have and so on? So a lot of those background characteristics that the individual brings into the situation can determine how quickly and how readily they are to go and seek help for any new symptoms, as well as various enabling factors. So we talked a little bit this morning about the FAA reporting requirements, peer support programs. So what is available to pilots and pilot trainees in terms of peer support programs? What strategies might they use to address their symptoms? So when they're experiencing a new symptom and recognizing that they need some assistance with that, are they right away going to see a healthcare professional, make that appointment? Are they relying on the internet and Googling the symptoms they're experiencing to try to get some information and some answers there? What do they know about their mental health care coverage? So these are some of the issues that we're interested in exploring in terms of predictors and what contributes to help-seeking behavior in pilots and pilot trainees. So as Dr. Hoffman had mentioned earlier, in collaboration here at UND with Dr. Beth Bierke, Dr. Hoffman, and Dr. Kaylee Trottier, we are examining pilot trainees' help-seeking behaviors in a qualitative study with the objectives of examining their perceptions of seeking physical health care and mental health care, hoping to identify what those perceived barriers are in terms of what the pilots view as being barriers and obstacles to seeking help and to disclosing their symptoms, both among U.S. military undergraduate pilot trainees and civilian collegiate aviation students. And we also hope to get a sense of what factors aid in that, in facilitating and fostering and enhancing that aeromedical provider aviator relationship, rather. So we hope to collect about 25 to 30 USAF active duty military undergraduate pilot trainees from San Antonio and Vance Air Force Base, and here at UND collecting about the same number of participants who are civilian aviation pilot trainees, rather. And we will conduct semi-structured interviews. We're hoping to do these virtually through Zoom, asking these pilot trainees about healthcare seeking behaviors and barriers that they view are in place to seeking the care that they might need. We will conduct a qualitative analysis of those interviews once they're transcribed using in vivo to get at the content, the main themes that come about in that research. And we want to compare those themes that arise from this qualitative analysis in terms of identifying similarities. So what overlaps in terms of perceived barriers between these two groups, and what differences exist that are unique to that specific population of pilot trainees in terms of their healthcare seeking perceptions. These are a few of the questions and topic areas that we will be asking about during these semi-structured interviews. So we'll get a bit of background information in terms of what their training environments are like, what are their responsibilities, what are their schedules like, what is their environment like as a pilot trainee. What are some of their barriers that they see in terms of preventing them or delaying that seeking medical care? So what factors might influence a pilot's decision to use or not use physical healthcare services when they're needed? What might influence their decision to disclose a new mental health symptom, so feeling depressed or feeling anxious during their aeromedical screening? And aside from barriers, we also want to know about what facilitates that healthcare seeking, right? So what factors might encourage their use of healthcare services and symptom reporting? And also, what what are some of the best practices? What are some of the things, as Dr. Hoffman mentioned earlier, that might be right there in plain sight that would be helpful, potential ways to improve disclosure of medical issues among pilots and pilot trainees, and what resources might they use to support them in seeking medical services when needed? So just to wrap up with some of the expected outcomes that we hope to get from this research. So we will compare the most frequent or most salient themes that come out in terms of help-seeking behaviors and perceptions between both groups, the military and civilian pilots, to highlight which barriers are most relevant to each of those groups. And we also expect some overlapping common lessons between the two groups that collectively could be applied to both populations. We also, as Dr. Hoffman had alluded to earlier, we hope that the study findings will help to inform leaders in military and civilian aerospace leadership in terms of what these barriers are, and as well what some of the protective factors are in terms of encouraging pilots to seek the help that they need and to report those symptoms that they're experiencing. And finally, we hope to inform future interventions to address these barriers effectively and to improve overall pilot access to health care. So, thank you. I'll turn it over.
Thank you for having me. And we do not have, I just want to say, we do not have the data yet on this study. I was asked to come to discuss our research design and methodology. We did receive funding to start. We are working with Naval Training Command, and we did get a grant to go ahead and start the study at SIU using our flight training program. And the Navy is interested in possibly moving this over to optimize performance in their UPT training. So, but we're working right now with our students at SIU. And so we'll have the first set of data by the end of the semester, and then the study will continue till the end of spring semester. And then based upon the data we collect, then we will move forward from there. So we, myself and Dr. Lee, who was unfortunately was not able to make it, he is with the Department of Psychology, Psychological and Behavioral Sciences. So let's go ahead and dive in. The problem that we're trying to address is, I think we'd all agree that there's stresses that accompany flight training, and specifically in collegiate flight training, and it causes a lot of anxiety and stress for students, and this is just the environment of which we operate in collegiate flight training. But we can't remove these stresses. So what efforts can we make to give our students skills to better manage this stress and anxiety and actually increase performance? There's been, I know that the Navy has done a lot of training of testing cortisol levels and putting, whether it be submarine commanders, pilots, under stress within the simulators, looking at their cortisol levels and seeing what happens with performance. And actually, you can increase performance with increased cortisol levels. There is a point of diminishing returns, but you can, with the right tools and skill set, actually optimize performance under high pressure situations. So that's what we're looking to provide for our students in the flight training environment. So the goal is to develop specific interventions that support and strengthen their resilience and to optimize their performance during that flight training. So giving them, a lot of, that is kind of a word you do hear a lot within flight training in mental health, is that psychological flexibility, that resiliency. So to drill down a little more, I want to go, that was our goal, but what are our specific objectives that we're going to try to achieve here? Development of performance-based acceptance commitment therapy, which I had never heard of that, coming from my background as strictly in aviation.
that's tailored to the needs of each one of our specific aviation students within our flight training program. So the way that Dr. Lee, when we first started talking about this project, and Dr. Giesman, who is an aerospace psychologist with the Navy, started talking about it, and how they explained it was stress and anxiety is not a bad thing. It's a normal human emotion, and you can actually harness it to increase your performance. And it's okay to acceptance commitment therapy. They say it's like dropping the rope. Instead of our students constantly focusing on how to deal with the stress and anxiety, which is taking up your time, when you should be focused on other things like your flight training. They call it dropping the rope. Is just, it's there. There's nothing you can do about it. Let's focus on, and we're going to get into openness and being present in the moment. But they said Dr. Lee told me, if I give you $1 million, you had to get up in front of a crowded stadium and sing the national anthem, and I cannot sing. And he said, it doesn't have to be good. Would you do it? I said, absolutely. And I don't know of anybody that would not. Now, I wonder if I said, you can't get your $1 million if you're nervous. So, he put you up to monitor your heart rate and perspiration. None of us would probably get the $1 million. So, when we tell students, just act like it's another training flight. Do you think you'd be able to convince me, standing in front of that crowded stadium, that, I'm just in the shower by myself? I'm not going to be able to do it. But I could push through. My heart would be racing. My heart would be, and I'd be sweating profusely, but I would belt it out, and I get my $1 million. So we're trying to train our students to do the exact same thing. So, and I apologize for those that are in the mental health industry. I did my best to try, coming from an aviation background. So we're conducting an open trial of the intervention and trying to determine its feasibility. Does this work? Can we increase our students' performance? Can we increase their motivation, their resilience, and just perform at a high level, again, in those pressurized situations, and address the specific students' needs to help them excel within this flight training program. So, and it was, we ended up taking Dr. Lee and some of his grad assistants that are doing the interventions with our students on Zoom, and we brought them over and took them up in a 310, and let them see, put them in the simulators and things, and let them see what our students deal with, and they walked away saying, this is overwhelming. So your students do all of this in addition to what every other college student does. And yes, they do. They're doing what every other college student does in addition to what we just showed you today. So the training, we want to increase, again, the emotional or psychological flexibility. One of the things that we've seen within our flight training is, we know once you get that sign off to take your phase check or your practical examination with the FAA, the sooner you complete it, the higher the likelihood is you're going to pass. And so the student will go through and they say, well, hey, we got an airplane, you passed, you're ready. We got an airplane later today, and you can get it done. Oh no, I'm not ready. Yes, you are ready. Okay, how about tomorrow? We've got. No, I can't. And we know that those that jump in and do it have a much higher pass rate, and those that slow roll and procrastinate, not yet, because their pass rate decreases. So that emotional flexibility to just roll and say, well, I wasn't planning on doing it today or tomorrow, but sure. Motivation, and again, just their performance. So specifically, to achieve those items, we're looking at 3 specific processes, and we're looking at openness, and that is looking at undermining your emotional avoidance. So looking at those internal feelings and experiences that you're having, and the more you try to control them, it actually backfires on you, and the more of those emotional and uncomfortable emotional feelings you will have. So again, that kind of comes back to dropping the rope, and you recognizing them, but realizing that you're spending all your time trying to control something that actually you're just making it worse. So to be resilient in the face of those uncomfortable because stress and anxiety and all that, it is uncomfortable. But awareness, and we're trying to reduce inattention and that rumination and worry behavior that inhibits your performance. Another thing we found from our instructors and our chief flight instructor, the assistant chiefs that are doing the rides, is that it's okay. If you make a mistake, if it's a minor mistake, you catch it, you correct it, you point it out. The check ride moves on. And until the examiner says we're done, you're still in, you're still passing. And so, but what happens is a student will make a minor mistake, and they may even catch it. And the check ride moves on, but they're ruminating about that mistake, even though it was minor. But the check ride is moving along, but they're not focused any longer. They're still thinking about what happened 10 minutes ago. So what are they gonna do? They're gonna make another mistake. And now it's snowballing on them. And now they're thinking about that. The check ride's moving on, and it snowballs until they eventually fail the check ride. So how can we get them to stop with the rumination, replaying things in their head, and be present in the moment, focused? What happened 10 minutes ago, it's done. The check ride's moving on. I am laser focused on what we're doing at this present moment. And engagement. And so they are getting homework to purposely engage in uncomfortable and unfamiliar activities to get them to, again, get out and get that flexibility and engage that these are normal emotions. So, and part of that is making attainable commitments and the plans that do come with that. So, okay, so again, it's a trial, not a trail design, randomized controlled trial design, and the participants are placed into two groups. And the students had no control and over which group they were put in. And group A, they are receiving the sessions. There's 6 of them, and they're 1 hour weekly. And they do complete the assessments, and the group B will complete assessments, but they do not receive any of the sessions. So what happens is they are screened for eligibility, and one of the factors for eligibility, for example, is you cannot be engaged in psychotherapy just because we want to know that our intervention made the difference. So there, if you are you get screened, and if you're eligible, you go through, and I'll show you here in a moment, a battery of tests that everybody takes, regardless of which group you're in, and then assessments, and then those that are group A that is receiving the interventions, they also complete assessments after every session, because what we're doing is not a cookie cutter approach. What we're doing is, depending on that initial assessment, what do you struggle with? Do you struggle with rumination? Do you struggle with flexibility, emotional fight? So they're actually tailoring their sessions specifically to each and every student. And then as they go through each session, they complete a few quick questionnaires, but again, it then helps the grad assistant or Dr. Lee then, again, change the sessions to specifically meet you where you're at and help you with where you maybe need some assistance. So it's tailored to each individual student and how they're answering those questionnaires. And then those that are in Group B, they do the initial assessment battery. They do a midpoint, and then right before their phase check or check ride, they will do that first assessment that they did at the very beginning. The A group, they're doing the same thing, except for they're doing those shorter assessments after every session so that they can get feedback and know how they need to change their sessions. And then they will also do a post-study qualitative survey to give their feedback on those sessions. And I will say, we don't have the data. I did talk to Dr. Lee before I came here, and he said his perception so far is that the students, our flight students, are really they're really enjoying it, find it helpful. And we've not lost any students that have just said, this is not helping me, because they can stop at any time. And everybody has stayed in the study. So I think that could possibly indicate that we're heading in a good direction. So these are the measurements, and it'd be like having somebody from mental health try to look at a METAR, and that doesn't make any sense. And so for me, I'm not going to go through. I did write them down, but I honestly, I'm not sure exactly. I do have the forms and the study, but self-disclosure, I don't know specifics about what each one of these assessments do as far as specifically the data that they do try to extract from the students, but that kind of gives you an idea of what what the assessments look like. And again, they have right before that check ride or that phase check, they have that last session to get them ready. And then, and they have, of course, then they'll have their post-study feedback as well. And so, based upon that, obviously that's where our qualitative data is going to be coming from the assessments, from their post-study. But we're also going to get that quantitative data. Approximately 20% of our students don't pass their FA practical examinations on their first attempt. And we're losing about 40 to 60% of students that just do not complete. Because we are restricted Part 141, we do have students that just can't get through our private pilot. So, they'll go to an FBO, another flight school, get it, and then jump back in with us but, we're losing about 40 to 60%. So, ideally, what we would like to do there is on the quantitative data is decrease the number of students that are not passing. So we want to increase that pass rate on the first try and obviously increase safety, because it all comes down to when you have a pilot that is not focused and thinking about that mistake they made 10 minutes ago, that's not the safest pilot. You want them focused. So all of this does drill down to safety and increase the number of students that we're able to retain in the program, but also ultimately, this is a skill set we can send them out to use in life, and specifically out in the aviation industry, because the stress doesn't stop once you get through your flight training. And to truly help our students deal with anxiety and stress instead of watching them struggle and not be able to do anything about it. So we want to keep them in the program, but we want to increase their safety, increase their performance, and just increase their quality of life and the ability to deal with the stress and anxiety that comes with being in our flight training program. So, and I kind of jumped ahead here on this slide, but it again, increased ability to manage stress and anxiety for our students, give them tools to work with, increase their mental wellness, and of course it all boils down to, safety. All right, and I thank you for your time, and I think we'll all take questions.
Going back to that conceptual study your design you're putting together, where you had the curve of burden of mental illness symptoms, where you had the purple and the red lines, is that getting towards what you would consider pathologic disease and mental illness? Because symptom burden could be high all the way on the left-hand side. So just talk through a little bit more. It's superb what you're doing. That's why I'm interested.
Oh, yes, sir. Yes, sir. Well, the important thing is that we found it so far helpful as a research communication tool. It's certainly, there's limitations in like what it means operationally. That red line would mean something very different in a 787 with 2 backup crews than it would in a B-52 bomber or in a Cessna 172. So recognizing that red line is dynamic and what that might mean. And it might be circumstantial too, like CRM might play a role in the dynamics of the crew where that line falls. So it's more conceptual. And so as it relates to transitioning between trying to screen for mental health, how might we go from a purple line to a green line? I don't know. From a research point, could we use things like technology, like more frequent screening, like in an iPad, using validated measures of mental health symptoms like PHQ-9 and GAD-7s more frequently, as opposed to periodic 6-month evaluations? I'm not sure what the answer is, but there's plenty of work to dig our fingers in and try and do some research to try to find some ideas.
That's great. This second question, this is for all of, well, it may not be the question as far as a comment, but it applies, I think, to all of your presentations. It's something I struggle with operationally and clinically is just the lingo that we use, communication, words like depression, anxiety, normal psychological reactions, abnormal psychological reactions, depressive disorder, clinical depression. Sometimes it's difficult when we're trying to communicate all these things and we see things on record. What do they mean clinically? So getting to all of your guys' presentations, which are great.
Maybe Dr. Heath, you want to talk about the health literacy project. That's a little early, but in a lot of ways we're asking, especially student pilots, to have excellent health literacy to navigate the aeromedical system independently, which is a whole skill in and of itself. And that's an open question. What do these terms mean to different folks, and do they have the tools to navigate the system? So another research opportunity and trying to, how do we address that in a meaningful way? I'm not sure if you care to answer or add anything.
Yeah, just very briefly. So we're about to undertake exactly that study as well, sampling hopefully thousands of pilots to get a sense of what their health literacy is, if they understand, sort of what do they do, who do they go see when they have a new symptom, what does it mean, and just understanding the jargon and some of the language that's used, critical to the communication and successfully achieving the care that they need.
Perhaps an opportunity for education in the embedded care curriculum. How can universities like UND, Embry-Riddle, et cetera, help empower students to have those skills to navigate the system if it comes up?
Can you all talk about some of the biggest hurdles you found in trying to do research in this, and then how to overcome them as people kind of come down the line and try and do follow-up research along the same lines?
It's a good question. I think a lot of it has to do with the individual institutions, and that I've worked with larger research, Carnegie Research 1 institutions and smaller institutions. So having that foundation for the research there, as far as some institutions will do you have grant managers and they find the grants, they manage the grants for you, and they make it much easier. When you're at smaller institutions, that can be much more problematic because you just don't have that support. But my advice would be, it sounds like UND has a great support system to help you through that process, but I would say get a mentor or somebody that knows how to go after these grants. And a lot of it also is collaborations, working with others and things, to other institutions and other individuals, and just kind of pulling together, because we're all trying to find these solutions, so we might as well work together because we'll get further together. But definitely getting a mentor and then working within any limitations that you have within your institution.